How do you handle death?
Except cardiac surgeons, nobody can understand that.
Any toxicity that you faced?
We used to work 36 hours continuously, all those things we did.
Let's suppose you are not able to do a 36-hour duty, then what?
Dr. Revanth Maramreddy. He is a gold medalist and MCh Batch Topper from PGI Chandigarh. In this episode, we will dive into the ground realities of cardiac surgery.
You can't charge much in this surgery. It's almost capped to almost 2 to 3 lakh rupees.
Doctor who did PG is getting 60,000, 70,000. After working for 6 years of MBBS, 3 years of PG,
I have heard a lot of times that this is a very toxic branch.
you will go mad. There are 3 halls full of patients on stretchers. At least some 300, 400 people will be there in waiting areas.
I've heard from a lot of patients that cardiologists especially tend to put unnecessary stunts.
We are minority of people. We are hardly some 12 lakhs. So if you go and post in Facebook or Instagram, more of criticism rather than appreciation over there. Random people will come and say you extracted money.
Hey guys, welcome to the Nachiket Bhatia Show. Today we are joined by Dr. Revanth Maramreddy. He is a gold medalist and MCh Batch Topper from PGI Chandigarh, currently operating as a Senior Cardiothoracic and Vascular Surgeon at Care Hospitals, Visakhapatnam. In this episode, we will dive into the ground realities of cardiac surgery, the fierce stent versus surgery turf war. He also opens about the heavy emotional toll of the operating room. So keep watching and make sure to subscribe the channel for more such in-depth and insightful conversations.
Why do even people say that this branch is a dying branch? Because till the time we can, get a honest answer about this branch. Because the people are still thinking that कि यार CTVS कौन लेगा?
Yeah.
खत्म branch है. जिससे पूछो, I talk to surgeons and they'll always rate this branch as the last one.
Yeah.
And they, for example, even plastic, they rate it low. But they never say कि don't take plastic. But for CTVS, they specifically say कि do not take
Yeah.
CTVS.
I will tell you 3 reasons mainly. As you said, the interventions are increasing. This is the common perception in the people that CTVS you won't get enough cases in the future. But that is not the case as we discussed. The case load is there and it will be there. The second one, the long learning curve. So it will take time for you to establish. By the time you finish MCH, you will be 32, 33. After that, again 5 years, you will become almost 40 by the time you settle. So this is one reason why most of the people are not, preferring CTVS. And the third one is mindset. Okay, the surgeries here, if you look at typically, they last very long, exhaustive. Minimum duration is 4 hours, I can say, on an average. So there are some other surgeries which you can do in 2 hours also, but on an average, we will spend for one case 4 hours in OT. If you do 2 surgeries, from morning to night, you will be in operation theatre itself. So that is one other reason. And outcomes also, at the present scenario, I can say the mortality in most of the setups where I have worked, it is around 2 to 3%. But still, it is higher than other branches. And most of the times, doctors may not be accepting the mortality. So unless you develop, typically when you take cardiac surgery, you should develop that heart to accept the mortalities. Okay. So these 3 reasons I found as the most common things for people not entering into CTVS. One is the long learning curve, the fear of interventions taking over, and mortality and duration of settlement. So, but if you are prepared to tackle these things, you can definitely take.
What was your mindset when you chose this branch? Because frankly speaking, I can understand the ROI part.
Yeah.
In a surgery, you can't charge much in this surgery.
Exactly.
It's almost capped to almost 2 to 3 lakh rupees.
Yes.
If I'm not wrong.
Yeah, not even 2 to 3 lakhs. That depends on schemes. So as I said, the system problems are there.
So normally, what is an average price for a surgery?
If you look at the schemes like Ayushman Bharat, central governments, all things.
I'm just saying from let's suppose a private hospital, all paid patient.
Yeah. So it is in tier 2 cities, we are charging for CABG 3 lakhs around.
Yeah.
And the problem is most of the patient will be having either some kind of scheme or insurances. In that they are paying very less. So even in Ayushman you will be getting 1,80,000 or something, and in CGH it will be 2 lakhs or something. So this kind of pay is very less for what we are doing actually.
And the time period to do this surgery is like 4 to 6 hours.
4 to 6 hours.
Now, comparatively, if I would say, if somebody has to do a TKR, in just 30 minutes, you can still charge 3 to 3.5 lakh rupees.
Exactly.
And you can do like 5 to 6
in
TKRs
a day.
without a problem.
Yes.
So considering that fact, and this has been prevalent in our industry for so long now, why did you choose this branch?
See, I am passionate about this. I never thought about money aspect. So I was mainly thinking about the satisfaction that I get. I don't think I will get any that kind of satisfaction and high if I operate on a hernia or appendicectomy or TKR as you said, or any fracture fixation. Only these kind of congenital heart surgeries, they will give immense satisfaction definitely. So I was interested in congenital as well. I did quite good number of congenital. I worked in trust hospitals where they do huge volumes of congenital. So that will give you a very good satisfaction if you keep money part aside. So that satisfaction is definitely more. But one thing I will tell for any doctor, don't just concentrate on money aspect. If your satisfaction is there in your profession, just pursue what you want. There are other ways to earn money. So that was my mindset from the time I have taken MBBS. I have never concentrated on earning money from this profession too much. If I can survive on the basic needs on this profession, other things we can take care.
I'll ask you some questions on turf war.
Okay.
All right. So it's again basically a rapid fire with you.
Yeah.
I'll describe a patient in one line. You tell me stent, surgery, or neither, and why. All right. Scenario 1 is a 45-year-old single vessel block, no diabetes.
Definitely single vessel disease. The existing literature says it is intervention stent, PTCA.
60-year-old diabetic, 3 vessels blocked.
Whenever there is a 3 vessel block, it is bypass surgery is better than stenting, and in diabetics the bypass will give better result than stenting.
75-year-old, severe aortic stenosis, too high risk for open surgery.
Yeah. So aortic stenosis, as we discussed, it will be better to go with TAVI. So the intervention, the aortic valve interventionally we can replace it. That is better option than surgical if he is high risk. Even nowadays, as the life expectancy is increasing, I have seen very healthy patients at 75 years. If they are healthy and they can accept the surgical risk, we can go with surgical. But if he is high risk, definitely TAVI is better option.
Also, there is a opinion, a perspective in the patient's mind that stent is a short-term procedure. I won't say short-term, I would say a very short procedure. बहुत जल्दी हो जाता है. And when we say bypass, they feel कि भाई पूरे शरीर में मेरा चीरा लगेगा, and they still have that kind of thinking.
Yeah.
And it's going to be a big surgery. So how do you convince the patient?
Almost 75 to 80% in my clinical practice, they will agree for the bypass. So now we have effective medicines and as I said, minimal invasive procedures where we can do with a less pain also and with minimal scar. So in those ways, we are trying to convince the patients. Otherwise, if you just explain the pain and duration, it is very simple. Even if you get stent blocked, it will be life-threatening. So in that aspect, the risk, if you see, almost both bypass as well as stenting will have similar kind of risks. I have seen patients in my own family, I have experienced, where the stent got occluded and, we lost my father itself. Okay. So these things, don't think that CABG is a very invasive thing, it takes long time. Definitely not. But though if you can accept that pain and things, the outcomes will be better in most of the cases. So these things we will explain them properly, and we will give them the chance to decide. Many people will agree.
There must be a line, clinically speaking,
Yeah.
कि till that line you have to do stunt, and post that you have to do CABG.
Yes.
What is that like?
As we have discussed, it is left main. Most of the places, the guidelines say CABG has better result than stunting, and but still some of the cardiologists are preferring stents. Just explaining them just saying that it is more invasive, the surgeries, all those things. But left main, always my suggestion to any patient or doctors having relatives with cardiac problems, go for bypass.
Is this a biased statement?
No, never, never. Left main, always bypass surgery. Okay.
So have you ever recommended a patient to go for stunt rather than CABG?
In left main?
नहीं, मतलब normally speaking.
No, I just explained. See, even in triple vessel disease, if scenarios, not favoring for the surgery, if he comes with acute MI, so if you have already stunted one vessel, later on the stunting has to be done even in triple vessel diseases also. There are such scenarios. But ideally speaking, if the patient is stable, like on general evaluation, if you are diagnosing him with the coronary artery disease, like TMT test, if he get it done, he has angina, and only patient complaints of angina on walking. If they are so stable, if you have time, always evaluate, and if it is left main, the surgery is the option. If somebody comes with acute MI having LAD occlusion, sometimes you won't get time to prepare the OT and take him for the surgery. So lot of logistic issues will be there. You need a very huge manpower for surgery, and you have to arrange blood. All those things will take time. So in those scenarios, if you do stunting for the culprit vessel, that's not wrong. But if you are doing it for a elective procedure, stable patient in triple vessel disease, that is wrong.
I've heard from a lot of patients that cardiologists especially tend to put unnecessary stunts.
Yeah, as I said, this notion is there. If you, to be frank, with a lot of heavy-heartedness, I have to accept. I have also witnessed some people doing this. So, but you have to select your doctor also wisely. Okay. So, but most of the times, whether it is necessary or unnecessary, if you have time, you get it done. You get it done means get a second opinion and decide whether it is true or not. But 95% of the doctors are not like that, just 5%. Okay.
Dr. Revanth, you have been in the medical field for almost 17 years now. Yes. You did your MBBS from Narayan, then KMC, your MS surgery, and then you did your MCH from PGI Chandigarh. So tell me about those 17 years.
It's very long journey, as you said, 17 years. So basically, I did my MBBS from Andhra Pradesh in one of the private medical colleges. So in my first step itself, I got a decent rank, but I am very, homesick kind of guy. So there's no government medical college at my place. So I had to take. And, to take MBBS, it is my childhood dream. So at third, fourth class itself, I have decided to take medicine, because my father's brother, my uncle, he is my inspiration to take medicine. So at that age itself, I have decided, and there is no other dilemma. So I have been traveling in that path from childhood itself. So he is a good practitioner at my place. So he said, you can join here. So you can come and see my clinic in the evening if you want a good clinical exposure. So he used to see 70-80 patients in a day those days. So I had a good clinical exposure during my MBBS time. After that, what to do after MBBS? Then during MBBS itself, I have decided to do cardiac surgery. So there is no dilemma again to take whether surgical branch or medical branch. For Manipal entrance, there will be during those days, I will tell you one interesting thing: NEET entrance. So we are the first batch to give the NEET.
17 batch?
No, 2013.
13, the
first time.
10-day NEET came.
10-day NEET came, exactly. It is not 10 actually, it is more than 10. So now recently, people agitated because of the two, sessions. We have almost given 30 sessions. Every day 2 sessions will be there.
Every day 2 sessions were
Two
there.
sessions.
10 days of NEET, 2
more
sessions.
More than 10 days. I have given 2012 November 29th. My first NEET. So it went almost up to December 12th or 13th in multiple, almost 13-14 days, every day 2 sessions. I don't know, God only knows how they have calculated all those things. But
At that moment, pro metric system was introduced.
yeah, Prometric was there. So they used to conduct at random places. Those centers also very far away from the cities. So that struggle was to write NEET. After writing, then simply they cancelled it. So that is the first NEET they have cancelled. We waited till February. Multiple court hearings happened, and the end of February they came and said everybody can conduct their own entrance. Then I got a decent rank, some 3,500 in NEET PG. Then everything went wasted. AP government has conducted their own PG. Then every institute conducted their own PGs. Then I luckily got in Manipal entrance. So there I got a good rank in 100. So but I was getting medicine also, but I was decided I don't want medicine, because if you see in hierarchy, most of the medical students, I don't know why, even if you are interested in surgery, if you get good rank, they will go and take radiology, derma or medicine, but nobody stick to their original plan. So most of the people does like that. Even after doing surgery, if you are interested in neuro or cardiac, if you get good rank, they will go and take uro or onco, because that people are already with a prefixed mindset. So this is wrong actually. I say, if you are interested in some branch, fix to that and do whatever you want to pursue. Just don't go with the stream. Okay. So then, as I said, after that I wrote the Manipal entrance and got into the KMC Mangalore. That is very, I am fortunate to did my MBBS in a private and MS in public private partnership, and MCH from a central institute. So I have experienced everything, the how the private hospital, how the government hospital, how the central government hospital, all these things. So that gave me good exposure, the clinical load and teaching.
I'll ask you a question here only.
Yeah.
Because so many people who are from private college, they feel that their career can never take off because they are studying in a private college. Tell me the difference between a private college and a government college.
See, definitely your attitudes matter more. The private college will never, stop people from going to the different level, because I have selected private college because of my personal reasons, and but only one thing is that when I was doing MBBS, there is no much senior guidance actually in very established, like very old government medical college. That senior guidance will be there. So that kind of guidance I could not get properly, how to prepare for the PG, how to orient all those things. Except that nothing is wrong in choosing. In fact, the academics are better in private colleges. They are better oriented, and even in Manipal, if you see, the professors are very regular and they are very particular about academics. They are excellent teachers, that I can say. So that is one of the best place that surgery teaching that happens in PG. And even MBBS also, the private colleges, they are very much stick to their study curriculum. And as of now, if you see in most of the institutes, even in government institutes, MBBS is becoming a kind of basic structure and knowledge laying. So you should have a good foundation of your academics during first 4 years. Internship will have a little bit of lag in private college. Definitely the caseload will be less. That is one drawback. But academically, private colleges are, even better than many of the government colleges.
Tell me honestly, what was your first choice for SS?
For super specialty,
First choice for SS.
first choice is CTVS.
Seriously.
See, one thing that I will tell you, now you have different entrance pattern. When I wrote entrance, there is separate streams for everything. I never prepared for any other branch.
No neuro,
No neuro, no
Euro,
euro, no
nothing.
onco, nothing. I wrote only CTVS in PGI, and because by the time I complete my MS, the AIMS is already completed. So when I gave PGI first time itself, I was selected. So then whether to wait for some more time and try for AIMS, those questions were there. But PGI, the Chandigarh is a decent place, and I don't want to experience so much of pollution of Delhi. So I have selected PGI and joined immediately instead of wasting 6 more months.
You were a gold medalist in your MCH.
Yes.
Tell me about your experience in PGI. Like, what makes PGI special?
See, PGI is one great institute, I can say. It serves a very huge area, and patient load is much better than AIMS also, I can think. There is more than 10,000 OPD is there in PGI. Every day you will every day 10,000 patients. Even it is there in online also. Mondays sometimes it will cross 12,000 OPD. So cardiac surgery alone will have more than 300 patients, and our volume of surgeries also huge. So there is almost like 6 months waiting list in those days. Now it's almost 7 years now. I don't know how it is, but cardiac surgery per se is a very good department and good teaching, good staff over there. So though work is a little bit more, but we enjoyed it thoroughly and we learned a lot in PGI. When I passed out from PGI, I kept goal for myself that within 5 years I have to become an independent surgeon. So then I started working in one of the trust hospitals, the Satya Sai hospitals in Bangalore for some time. So after that, then I went to Manipal as assistant professor. These two places helped me a lot. Even in fact, I could become independent within 3 years itself. So after 3 years, I started working as an independent consultant in Manipal. Then I moved back to my place, that is Andhra Pradesh. So I'm practicing now in Vizag. So within 3 years, I could able to become independent surgeon because of very good mentors actually. So the places where I worked, they helped me, because the one common notion in cardiac surgery is that you won't get good chances. The senior people may not encourage you very well, but definitely there are people who encourage. You have to choose those people. Okay, so if you go to them, they will train you well, and you can become very fine surgeon early.
Tell me about the toll it takes to become a cardiac surgeon. Your workload in your residency days, any toxicity that you faced, because I have heard a lot of times that this is a very toxic branch.
See, one thing I can frankly say, the working hours were bit more in PGI or any other institute, but I never had toxicity in the department. Department at PGI was very cooperative and helpful for us. In that way, if you have toxicity from your seniors or from the staff, that is more painful than working hours, I think. If you are forced to stay there and do continuously in emergency or ICU, that is definitely difficult. Having on call duties, those kind of things we can manage.
Have you ever seen a resident break down because of pressure?
Lot of such things I can say in PGI. So at least 10% of them literally get pulmonary tuberculosis because they don't have a proper breakfast, lunch or nutritious food. Lot of them have taken ATT, anti-tubercular therapy. So many of my colleagues, my juniors, they are there who have taken ATTs. So that kind of breakdown is definitely there, but somehow they cope up and do all those things. That exhaustion is definitely there in central institutes and high volume institutions.
So shouldn't we call this a form of toxicity? You are asking somebody to run for, let's suppose, 100 kilometers, not giving them a break. I mean, you love it, perfect, but 90% of the people cannot run 100 kilometers. They are exhausted, they are tired, they are not able to take a break.
For that, the system has to change. That somebody has to take an initiative and run the system properly. And if you look at the casualty in PGI, you will go mad. There are 3 halls full of patients on stretchers. At least some 300-400 people will be there in waiting areas, and you don't know which is your referral. It is difficult to find out over there. So such toxicity inside casualties, ICUs will be there definitely, but that has to be streamlined. So whether we can refer them back to some other institutions, patients who can be managed at smaller hospitals, they can be sent back there. That system organization will take time, but somebody has to take an initiative at an administrative level to do all these things.
I'll ask you an offbeat question. What is your opinion that every year the government takes out a 0 percentile and suddenly everybody is eligible to join MCH?
This is actually wrong. I don't know how somebody is getting minus marks is joining the NEET PG. So that
I'm not talking about NEET PG now, SS.
Yeah, even NEET SS also. There should be some criteria or cutoff. If somebody is not getting 50th percentile, they should not be eligible ideally. So that has to be changed. Just to fill the seats you are doing, and there is a lot of systemic things has to be done. So at present Indian population is hardly 150 crores. So already you have 13 lakhs plus doctors in India. So they are allopathic doctors, I am telling.
I know.
Okay. So if you are producing 1,30,000, 1,40,000 doctors every year, so the already we have reached that ratio of 1:1,000. What these other people are going to do? You are just filling the seats, and once they come out, they're not getting good pay. Okay, now hardly in metros or tier 1 cities, doctor who did PG is getting 60,000, 70,000 after working for 6 years of MBBS, 3 years of PG. That's why they will compare obviously with other professions. They are getting after 4 years or 6 years 50, 60,000, and we are also getting the same thing. If somebody is not focused or dedicated about their profession, they will definitely feel exhausted. So after so much of struggle, we are getting so less. So for this reason, government has to rethink that. They are fantasizing and projecting in such a way in southern parts also, I can say. If you have more number of medical colleges and more number of seats, they are doing some development. That is not the thing. You build a hospital, recruit the doctors. Why you want medical colleges everywhere? So there is one place in Andhra, they have built a medical college that is a tribal area. Okay, so good, their initiative, I am not any questioning them. But one thing, the NEET now opened up for the country. If somebody from Delhi want to join that place, they don't have proper bus service there. How they can travel? If they get down in Vizag, that will take almost 3 hours to go there. There is no proper facility to travel. So why you are forcing people to go to such places? You can build a 100-bedded super specialty hospital there, recruit some doctor, let them serve. It is not that if you are providing a medical college there is a kind of healthcare provision. That thinking should be gone. It should be abolished. So every state according to their population, the medical seats has to reduce. Okay, now the Tamil Nadu, Karnataka, Maharashtra, including Andhra, Telangana, they are having excess number of medical colleges. That has to go down. That fantasy should come down. Having more number of medical colleges and seats should not be celebrated.
I'll ask you a couple of questions. Again, a rapid fire.
Yeah.
Expectation versus reality. I'll put out a statement and you have to answer me whether it's expectation or reality. Once you are in PGI, you have made it.
Expectation.
MCH means you are a cardiac surgeon from day one.
This is reality, but the struggle will continue.
After CTVS training, the world is your oyster.
No, nothing like that.
It's the golden age for super specialists in India.
At present, for another 5 years. After that, it will also get saturated, as I said.
And you have to do sub-super specialization.
And no, even whatever you do, after a certain stage, it will get saturated and your income will definitely go down.
The professional journey of a super specialist surgeon, especially in the field of cardiac surgery, starts after 40 only.
Yes, this is true. This is reality, I can say. And as I said, you will take at least 5 years after MCH. Your career will almost start after 40, and you can't work more than 60 also. So your span is only 20 years. Whatever you can, if you are exclusively earning from your profession, you have to plan in the 20 years.
Study for 20, earn for 20,
and for 20,
die after that.
Yes. As the recent studies say, the average life expectancy of doctors is 58 or 59. In India and the general population, it is almost 70 plus. So we are 10 years less than the general population. So by the time you retire, you will be gone actually.
Okay, women in this field today,
Cardiac surgery.
What's the current real situation?
See, now if I see when I did MS, out of our 10 people, there was only one girl. But now the scenario is changing. More number of girls are taking medicine. And after that in PG, they are taking surgical branches also. The ratio has almost come to 1:1 now. So, but definitely for the woman, there is no any discrimination. If you feel you can, tolerate that long surgical hours, and if you are communication skill, everything is good, then you can definitely take this branch. There is nobody stopping them from taking. But only thing is prolonged working hours. That kind of stress they should be able to tolerate. First, decide for that. If they are willing to take, it is equally good for them. A lot of my friends are there, my juniors, my colleagues in cardiac surgery also.
A realistic salary structure of a cardiac surgeon immediately after MCH, 5 years down the line, 10 years down the line.
Yes, so immediately I can say if you are working under somebody for training for another 3 years, you can expect around 2 lakhs. After that, if you work for 3 years and if you start doing independently, you can earn around 4 to 5 lakhs. So once you cross 8-9 years of experience, you will get somewhere around 7 to 8 lakhs.
And is there a salary cap?
No, after that it will keep on increasing depending on your communication and your patient load that you are operating. But this is overlying salary structure that I am telling. Immediately after passing, you will get 2 to 2.5. Within 3 years, around 4 lakhs, and after 6 to 7 years, around 7 to 8 lakhs.
Dr. Revanth, you have lived in Chandigarh, Nellore, a couple of more places.
Yes.
Yet you chose to come back and practice in Vizag.
Yes.
You could have stayed in a metropolitan. But
Yeah.
why Vizag?
So see, this one, even I am, I have seen people why they are so much obsessed with metropolitan. I don't understand. For the existing, medical, fresh postgraduates or super specialists, you better choose tier 2, tier 3 cities, because there are more opportunities for super specialists in those places. After 5-6 years, they will also get saturated. So only thing, the common point that I came across is their kids' education, the quality of living. So tier 2 cities will have a very decent quality of life, like any other district headquarter places nowadays. So try to choose those places. Your income will definitely go by 30%, I can say, compared to metro. And you can practice over there for some time. You will get a good clientele, and your income over years also will increase a bit more rapidly than metros, because a lot of senior people will already established. It is very tough for you to compete with them and attract the patients. So better is to, for the younger generation, better is go for tier 2, 3 cities.
I want to get into what you actually what you actually do on the OT table. You operate on a beating heart. Tell me, how's that experience?
Yeah, it is actually initial days. It will be so passionate, so fascinating as well. And see, we are not operating on beating hearts in all the procedures. The beating heart bypasses are there now. So what we do is, if you want to work inside the heart, like valve replacements, all those things, we will stop the heart actually. So it is, we will connect the heart to a bypass mission. So where the function of the heart will be done by a machine outside. So we will just connect the heart to that mission. We will give a solution to stop the heart. Then we will open the heart. We will replace the valve if it is valve problem. And if it is pediatric cases, if there is any hole or something, or any problem with the vessels, all those things, we will fix it. Then again, we will slowly start the heart and we will take it out from the mission. So this will be the most fascinating, part of the cardiac surgery. So as recently in one of the podcast, Dr. Devi Shetty also said, so if you are doing surgery for a blue baby and coming out of OT, with a pink color, so that is the most satisfying thing for any cardiac surgeon. So like that, cardiac surgery is really, most satisfying thing that anybody can do.
India is one of the best countries for these transplants. Beating heart bypass surgery, off pump surgery. How did India actually got so good in this?
Because that actually, the necessity make the things happen. In the same way, because we in India, we will celebrate the things that we do at a lower cost actually. So as the system pushes us to do the things at a lower price, so what, as I said, if you want to put heart on a bypass mission, arrest it and do it takes lot of consumables and efforts. So even today, most of the Western countries do more of bypasses on arrested heart than India. Okay, this is more surgical skill oriented, the beating heart surgery. But we are doing it because the consumables will be less, and we are doing it at a lesser price. So if you are doing a bypass beating heart, it will take very less number of consumables, and the charges will come down, so that we can do it at a lesser price, and we can tell the hospitals that you can charge less to the patient. Because of that reason, we are doing more number of beating heart surgeries.
How is it like operating on a child's heart? It's like a newborn baby's size is almost just like a strawberry.
Yeah.
So when you are doing that kind of surgery, pediatric CTVS,
Pediatrics, yes.
the number of people who are doing it is already less.
Yes.
What's the kind of experience you get?
See, pediatric hearts are so gentle, and you have to manipulate them with a very lot of efforts. Okay, so pediatric hearts, they are not like adult one. You can't give the regular cardiac supports. So pediatric, the problems also, if you see in adults, there will be only two conditions mainly. One is coronary occlusion or wall. In pediatrics, this is a very vast subject, and the kind of diseases also very vast. There will be, it can be a hole in the heart like ASD, VSDs, or sometimes it will be malposition of great arteries. Sometimes their lungs are draining into other chambers, and valve occlusions. There are plenty of different spectrum it is. Okay, so addressing them need a very meticulous anatomical knowledge as well as physiology. Because if you see operating on 1 month child and operating on a 4 5 years child for a same problem, it is not considered equal, because at 1 year physiology will be different, at 4 years physiology will be different, at 1 month physiology will be different. Because at 1 month, if you see, the neonatal pulmonary hypertension will be there, so that will come down later. After that, once you grown up like 4 years or something, because of these shunts, the pulmonary pressures will vary. All those things you have to understand, and you have to think and go with a proper plan in case of pediatrics. And you won't get much of walls, all those things. Recently, if you see, there is one thing got viral actually. One Indian origin cardiac surgeon did one heart surgery in US, and he placed the valve upside down. If you have listened, so this thing I can say, no doctor can place a heart valve upside down. It may be any patient. Okay, so even I did one case, pediatric, 4 years. The child has already underwent surgery in Bangalore in one hospital. So they are from Chhattisgarh. They landed up to me, and so I have to operate again on that child. The valve they did repair initially, that again got damaged within 2 years. So now I don't have any other option than replacing the valve. At that age, 4 years, the valve will be very small. You won't get prosthetics that size. So what we have done is, the smaller valve that has to be placed in a different location, we have reversed it and placed it here. So the child worked, it worked well for the child, and child went home happily. So even in this scenario also, same thing would have happened. But except cardiac surgeons, nobody can understand that. Everybody is saying that he did something wrong, all those things. But luckily they could able to send the child to some other institute. They did the corrective surgery as well. But this kind of notion that somebody will do wrong, nobody can put a heart valve, even voluntary also you can't put it upside down, unless you are prefixed to do it in that way. On table you can't do by mistake.
So how do you handle death? Because this is a branch with a decent rate of mortality.
Yes.
When a patient dies, it becomes more of the family who is waiting outside. At that time, as a surgeon, what's going on in your own mind?
Definitely, it is very stressful thing to handle death of a patient. So most of the times what happens is, if the patient preoperative condition is critical, we will explain them the high mortality chances, all those things. In those things, it is okay. Most of the times they will accept. The problem comes when a young patient who is very much fit, if some unexpected things happen and he dies, that is the most stressful thing you can ever have. So it is definitely difficult for any not only for cardiac surgery, for any other field of medicine, difficult to explain them. But we have to sit with and properly explain what happened. Sometimes you can't give what exactly the reason. Sometimes even patient collapses after giving anesthesia also. So whether what exactly the reason, we have to tell them if it is identifiable. And sometimes they will go a bit harsh, or sometimes, but rarely I haven't encountered such situations. We will deal with them in a proper way and convey that what happened exactly without hiding anything.
And for you,
For me,
what is going on in your mind when you
yeah,
see
it
death in
is
front
very
of you?
stressful actually to handle. It is difficult to accept initially, but we will repeatedly counsel them. So the condition is critical. No, at once they won't die. By the time if somebody had arrhythmias, we will try to revert them. Okay, so we will keep on explaining and conveying what is happening to the patient inside, and slowly we will tell them how the things are going on. Then we will reveal them. If we go and say patient is dead, everybody get angry and they won't accept. You have to convey them in a stepwise manner that the patient condition is not doing good. And in OT, something if happens, there are a lot of ways to at least bring him out, like in bypass, if the patient's BP is not maintaining, we will put them on aortic balloon pumps, or sometimes we will put them on ECMO also. All those things we will do and we will try definitely. But still, if something cannot be done, we have to explain them with heavy heart.
Have you ever faced violence when you told the family that the patient died, and suddenly
Violence,
things?
some one or two incidences where they will get anger, but never like shouting back or beating and those kind of things. Some they will ask how they will how he can die. He is very much fine, and while taking to OT he is good. See, when we are taking him to the OT means, I will tell them, if he is healthy, why we will take. If you see in YouTube lot of videos, they will say patient came walking healthy, but he died. So why patient will come to hospital if he is healthy? That's one thing I will ask. So all the cardiac patients, or many of the surgical patients, they will come walking unless they have some fracture or anything, or some cerebral CVA kind of thing. So patient, most of my patient comes walking only. But if as you said in one of the scenarios, severe LV dysfunctions, those kind of patients, we will explain before taking the procedure that it is high risk. Once you prepare for at least 10% 20% of mortality, then only we will consider for surgery, otherwise we can't.
Let's talk about your entrepreneurial journey.
Yeah.
You have a startup also.
Yes.
All right, tell me about it.
So actually, I'm, I have very dedicated mind towards this profession. So I want to do something for the medical professionals, I thought. So as I said, after preparing, after finishing my MCH from PGI, then I went to Manipal to work as assistant professor, and did worked for 1 year in Satya Sai. Then I came back to Andhra Pradesh. So during this time, I had lot of problems with the medical registration. Just honestly tell me, so everybody is reading the same medicine. There is no separate for Andhra, separate for Telangana, or for Delhi, or any other state. So then why every state will have separate registration numbers? Why can't an Indian doctor practice anywhere in India? So if you one hard thing is, if you have a registration in one state, and if you want to go and register in other state, he has to take NOC from there. He has to register here again. And if you go back after 5 years, he say your registration is expired here. So I have taken NOC from you. You only gave me NOC. How my registration will expire here? So there are no answers. For this part, there is no streamline in the system for medical registrations. So this is the toughest part I have experienced during my transition from PGI to Karnataka to Andhra Pradesh. So that time I thought we should have one platform where we can discuss our professional issues. And if you see, there are multiple doctor WhatsApp groups somewhere I find. So do you have any known doctor practicing somewhere? I want to refer a patient. So that there is no communication, proper communicating channel between among the doctors. So if I want to refer one patient whom I know in a different place like Bombay or Delhi, so I don't know who is practicing here, the neurologist or endocrinologist who is there. So there are a lot of non-medical people are intervening. There is a entity called hospital marketing. So all the MBA guys, everybody is sitting, they will go and meet doctors, they will ask them to refer here. Why you need such a system? So if a doctor has his patient, if he want to refer to other doctor, he can just directly search for him and identify them. So I just want to build one of such platform where all the doctors can connect, and so that they can share their professional issues also, and they can have a connectivity so that patients can be smoothly referred among themselves. And also if you have any like a good case to discuss, so you can share there itself, because as I said, we are minority of people, we are hardly some 12 lakhs. So if you go and post in Facebook or Instagram, more of criticism rather than appreciation over there. If you say I have treated this kind of patient, I lost the patient, but they are very harsh. So random people will come and say you extracted money, you did this mistake, that mistake. Our professional issues they won't understand. Only a doctor can understand other doctors' problem. So I thought we need one platform where you can discuss all these things. So as I said, I am the first person to write NEET in 2013, 12 for the 13 session. So those days it was conducted in 30 sessions. So now if you recently for 2 sessions, there is a lot of awareness that they have cancelled and they conducted it in 1 session. So that kind of awareness will come only when we project our problems. So I want to make such platform where we can showcase our professional issues. So we have built this platform called Doctrine. So this is a doctors networking and a knowledge sharing platform kind of thing. So there are multiple other things we are planning to do through this. We are planning to come up with online CMEs. And in this, one beautiful thing is when a doctor registers in this, they will depending on their departments, they will be segregated separately into different forums. So any departmental things like any new update or any departmental CMEs, all those things they can discuss in their own departmental forums. So this is a very comprehensive and well structured platform for doctors. We are planning to come up with lot of updates on it. So now as the NEET and all these things notified, we are planning to conduct NEET academic activities and postgraduate academic activities also through this platform. Yeah.
Thank you, Dr. Revanth.
Dr. Revanth, 8 years in a branch everyone keeps calling dead, and you answered every claim honestly. The money, the loneliness, the deaths, and the reason you had still chose it. Thank you for that. If you are a student watching, comment the one thing about the branch that changed you for today. And if you know someone standing at that CTVS versus cardiology crossroads, send this to them. And as always, if there's a branch or doctor you want us to have a chat with, drop the name in the comment section.